Hello, everyone. Hope you can hear me. Welcome to the Center for Health Equity in Surgery and Anesthesia at UCSF Grand Rounds, virtual Grand Rounds. Today, we will be showcasing voices that are emerging in global health and surgery. I'm very excited for this webinar. I think we can all attest that early exposure to global surgery can really change the trajectory of our careers. It can really inspire passion. And I can certainly attest that it's affected my daily professional life and my career goals in really positive and unexpected ways. And so I'm quite thrilled and quite honored to be a part of the webinar today, to be listening and learning from several truly excellent early rising career professionals whose passion and grit for the work of global health and health equity in surgery will truly change, I think, the trajectory of our fledgling field. So one such early professional is our own UCSF medical student, Eric Kim. Eric was originally born in South Korea. He moved over to the United States at the age of 9. His interest in immigrant health led him to pursue medicine, and he has since expanded this interest into health equity for surgical care while he's been in medical school. So Eric is currently the president of our UCSF chapter of the Global Surgery Student Alliance. And I'd like to turn over the webinar to him to introduce our panelists.
Thank you, Sri. Before I introduce our panelists, I'd like to remind you this webinar is being recorded. I also want to encourage you to submit questions via the Q&A function as well. We will have time to ask our panelists questions towards the end. If anything we discussed today speaks to you and you would like to tweet or post about it, please tag us at UCSF_CHESA and use the hashtag CHESA Grand Rounds. Now, today we have the pleasure of welcoming 4 wonderful panelists. Our first panelist is Rohini Dartha, who is a MS5 at Christian Medical College and Hospital Ludhiana, and a research associate at the NIHR Global Health Research Unit in Global Surgery at her medical school, and a global surgery fellow at the WHO Collaborating Center for Research in Surgical Care Delivery in Low Middle Income Countries, India. As an Indo-Canadian living in India since 11 years old, she encountered and was sensitized to disparities in the healthcare system at an early age. She strives to channel her earnestness to provide surgical care in low-resource settings and improve women's health by training to become an academic obstetrician gynecologist. Our second panelist is Isabella Faria, who is a medical doctor and research associate at the Harvard Program of Global Surgery and Social Change, PGSSC. She earned her MD at UFMG, Brazil, and was elected vice chair of the Association of Academic Global Surgery. Living in the country with the largest free universal healthcare system in the world, she learned early in medical school to advocate for patients' rights and the importance of connecting both research and healthcare policymaking. She aspires to become an academic surgeon and help increase access to surgical care and surgical capacity worldwide. Our third panelist is Srina Kundu, who is a research fellow at the Harvard Program of Global Surgery and Social Change. He completed his medical school from the West China School of Medicine, Sichuan University, and went on to earn his master's in experimental and global surgery from McGill University in Canada. It was after the extraordinary medical response during the disastrous earthquakes in China that he understood the need and importance of international collaboration in disaster management and global surgery. His experiences motivated him to continue collaborative research with projects in China, India, and Canada. Our fourth panelist is Joyce Kalungji, who is an anesthesiologist at Kawempe National Referral Hospital. She completed her medical school from Mbarara University of Science and Technology. She recently completed her master's degree in anesthesia and critical care from Makerere University in Kampala, Uganda. Her interests are critical care, thoracic anesthesia, and antibiotic stewardship. Now that we've done some brief intros, we will have each of the panelists briefly discuss their background and work, and after move on to some questions. So first we'll have Rohini.
Thank you, Eric, for the very kind introduction, and good morning, everyone. I'm Rohini Dartha. I am a medical student in India, and I'm honored to be presenting to you today and taking you through a glimpse of my journey and work in global surgery. I spent 5 years of my childhood growing up in Canada, where my experiences allowed me to develop the ability to think beyond conventional norms. So when I moved back in grade 7 and went on to becoming a medical student here, the same experiences drove me to take action, build networks, and lead change for students through the Asian Medical Students Association of India. 2015, as we all know, was the landmark year for global surgery. But 2020 was personally the landmark year for global surgery for me in the field. As I grew up, as I grew up and I became a medical intern in the beginning of 2020, when the pandemic had struck our country, I was posted in a rural hospital. At the same time, on social media, I came across the word global surgery and the concept. As I deep dived into articles and began reading more, some questions emerged in my mind, particularly how I could not understand the work that we were doing at a rural hospital could be relevant at a global level. I could not understand what is so different about global surgery research and what are the components that are different from normal clinical surgical research that we usually do. And something that I was surprised by was the fact that majority of the research in low middle income countries and even in India are largely being driven by scientists from high income countries. The most important question as I began deep diving into conversations and articles was, what can I do in this field? So when I returned from my rural posting, I realized that although I was being equipped to handle surgical conditions clinically in rural and austere settings, I did not have the skill sets to engage in this field academically. So I joined the NIHR India Hub for Global Surgery at my institute as a research associate, and later on also became a global surgery fellow at the WHO Collaborating Center. The beginning of my journey in global surgery research occurred through several international collaborative projects, which were occurring with the NIHR. Talent, which was a study within a trial, was my first project in which I was a data collector. I provided telemedical care through audio and video calls to nearly 150 patients. I also learned REDCap, and I was also part of the writing group of the paper. Similarly, a very famous COVID Surge Global Surge Week study occurred. Initially, when I was a part of this study, I was just collecting data from patients, and I thought my role was pretty minuscule. But it was not until I saw my name amongst a long list of authors alongside surgical superstars, I realized the impact of the results from the papers that were being published from the data that I collected and how they were impacting surgical care at a global level. And this is when I also realized that if you contribute to something wholeheartedly in the grand scheme of things, it will be worth it. And also, of course, the true power of collaborative work. My most fulfilling experience till now has definitely been my time as a global surgery fellow. The work I have been engaged in with a group of talented and committed researchers across the world has truly been multifaceted. We have done work in and continue to do work across trauma, healthcare system strengthening, increasing access to blood transfusion, systematic and scoping reviews, which are everyone's favorite, and also leading several multi-center studies in India as well. This work has not only enhanced my skill set as an individual, but also made me much more empathetic and given me a core group of supporters for my career throughout life. COVID came with some silver linings, and for me, it was the online and free global health events that I was able to attend. Through all these events, listening to my colleagues, discussions with my peers in breakout rooms across the world, and all the wisdom imparted from senior surgeons on what decolonizing global health is, what it is to be an ally to the LGBTQI community, and really understanding what academic global now entails helped me a lot. I also, through these experiences of talking to people and discussing things, I recognized and now continue to remove my own implicit biases that I did not know before even existed from the colonial mindset that we tend to grow up in India specifically. So till now, through this year and a half of a journey, I have learned that working in global surgery is truly all about listening. I realized the need for medical students in LMICs to be informed of their role and for them to be engaged and empowered to leverage all opportunities. However, I do recognize that in India, and myself included initially, we always tend to fall into a very victim mindset where we think that we don't have these opportunities, we don't have these resources, how will we pace ahead? But if you take matters into your own hands and ask what you can do and continue to ask that, the unimaginable is possible, such as me presenting here today. So with this incredible inertia that I've built, and as I pace ahead in my own career, I have several projects in the pipeline which are at the intersection of global OB/GYN and trauma care, health systems, and health technology. But I would like to take a moment to recognize that my journey in global surgery has been one of extreme privilege, and that to get to where I am today has largely been due to academic affiliations of the institutions that I am currently involved in. But the truth is that people working in global surgery for decades are not necessarily affiliated with these institutions. And my goal is to amplify their voices because they are the true unsung heroes of surgical care. And in order to achieve this, I hope to engage in advocacy and learn more on how health policies are shaped to particularly improve women's health throughout. A wise friend once told me that one mentor is not enough to fulfill all my mentoring needs. So I built a network or a pyramid, as you can see. And all that I am today and all that I am yet to become, I owe it to them. Thank you so much for listening. And I pass the baton to Eric.
Thank you so much, Rohini. We'll have our second panelist present next, Isabella.
Hi, everyone. Let me just share my screen. Okay, well, Rohini spoke beautifully, so I'm sure everyone was inspired by her talk. Let's see how it goes with mine. So I like to start with this sentence from Paul Farmer. He's, for those who don't know a lot about global surgery, he is considered one of the fathers of global surgery. Everyone knows his history, and he has a really, really inspiring history. So you might want to check it out later. But he says that global surgery is one of the most exciting frontiers in a quest of global health equity. And patients and providers, along with those who set and evaluate policies, will want or need to join this quest if we are to avert unnecessary suffering. So I think this sums up very much what global surgery is, because it's a search for global health equity, and it needs everyone to be involved. So patients and medical providers or other healthcare workers, and also those people who set and evaluate policies. So the government people, policy-making people, and even other associations like the UN and WHO. So everyone is very important in global surgery. And I think this sentence really sums this up. So having said that, I wanted to present a little bit about about my history in global surgery. I know that there are many medical students here, especially from low and middle income countries. So I think it's nice to know, and Rohini, I think she did the same thing. So this is great. How everyone has a timeline and how everyone got involved with global surgery. This is one of the questions I get the most. People are always asking me how to get involved and how to be a research associate or how to do research in global surgery. So I think it's good to know that it didn't come up from one day to another. It was a series of things, a lot of steps that I took that led me here. And I think it all led me to get to know a little bit more about global health and global surgery, and to actually enjoy learning more about the other healthcare in other countries. So in 2017, I had a scholarship as a teaching assistant at UFMG in health policies and planning. And this is where I first started learning about other healthcare systems in the world. And I also did a transplant surgery observership in France, which was really interesting for me at that time. I was in the middle of medical school, and it was the first time that I saw with my own eyes how it was in another country to be in a public hospital and how things work there. And I could compare it to my own country for the first time. And I think it was really enriching. So I wanted to do this again. And in 2018, I did another observership, this time in the US, was a transplant too. And I also did some liver research right after at Yale. And I think this led me to acknowledge more about the differences and to start learning about the power of health policies and the differences in health. So this transplant observership that I did was in a hospital that the largest part of the patients there, they were from Medicare and Medicaid, which is something that we don't learn about when we hear about the United States healthcare. We usually hear that it's very expensive and that people don't have a lot of access to it. And then I got to see another part of it. And then when I went to do research at Yale, I got to see the other half of the patients. And I also worked in a veteran hospital. So here another set of patients. So it was really interesting to really see people from different backgrounds and from different countries. And I think this is where I realized it was kind of a turning point in my life. And I realized that I wanted to work more abroad and to learn more about the healthcare systems in the world. So in 2019, I joined Team PGSSE Brazil. It was starting in Belo Horizonte, where I live. And it was really interesting to start working with it from the beginning. We had started working with a pediatric trauma project. So I was collecting data, just like Rohini said. I think a lot of people who started in research, they do the same thing. So I was collecting data in night shifts in a trauma hospital, big trauma hospital here in my city. And after a couple of months later, I applied to PGSSE for the first time. And in 2020, I got accepted. I think in February, I got the letter of acceptance to PGSSE, and I decided to defer my position because a global pandemic started, and I wanted to try to have the opportunity to go to Boston, so I deferred it. I'm still in Brazil, so yeah. But anyway, even remotely, I decided to found the first Association of Women Surgeons chapter in Brazil with the help of my amazing colleagues at UFMG, which I was a student then. And it was really cool because it was one step further to study about global surgery and about access to surgery for women. And then I also joined GIGS, which is the Gender Equity Initiative in Global Surgery, which I heard on Twitter, which is something very good for you students that are hearing today. Twitter has a large medical community, so you can search for #MedTwitter, and maybe you can hear about these opportunities too. It was there that I first heard about AWS and about GIGS as well. So I applied and I wrote a little bit about me, about my background. I'm sure that all these previous experiences helped a lot. And I joined it as an advocacy chair. So I was there as chair for a year, and I learned a lot. I helped spread the word about global surgery. We had people from many, many countries there. It was really amazing to meet people from really diverse backgrounds and to discuss these pressing issues of gender equity in global surgery. And then in 2021, I finally started in PGSSE as the research associate. So now I'm working a lot with some countries. So I'm working with Brazil, India, and Guatemala, basically. And I was also elected as an associate member for diversity, equity, and inclusion at the Association of Academic Global Surgery. And I was chosen as vice chair for the associate committee as well. Associate in this case means I'm a medical doctor instead of a student. So I just wanted to show you a little bit, because sometimes what I see is that people don't know where to start. They don't know a lot about global surgery and they want to get involved. And I think it's nice to know that you can start getting involved piece by piece and doing a couple of small things and helping in some projects, just like Rohini said before. And you can grow in this field as time goes. So I wanted to just give a little glimpse of you. I'm not going to say a lot about this, but about healthcare in Brazil. So we have a free universal healthcare system. What does this mean? We pay for it with our taxes. So we don't actually have to pay if we go to a hospital or to see a doctor for any reason if we use the SUS, which is our healthcare system. It's used by about 2/3 of the population, because about 1/3 likes to use private healthcare, but it was created to really be able to attend the 10 million people in Brazil, all the population. This is a picture of one of the primary care centers that we have, just to illustrate. I also wanted to say that when I created these slides, we had 1.6 million people vaccinated with COVID vaccine, which is a very large number. And Brazil is also actually known for to have a very, very large coverage of vaccines. Usually we have 90-something% of the population vaccinated for anything. We have a very nice culture of vaccination, and just wanted to show you that it's a really good healthcare system. It really works. So the base of it is the primary care health system. So if you have anything, usually if it's not urgent, you go to this one of the centers like in a picture, and you schedule a consultation, and then you meet with probably a generalist or family medicine doctor, and you get to be there for like an hour speaking about your life and everything related to your social health and about your health in general. And then you can usually get a medication for free as well. There are many medications for free. And if you have an urgency or an emergency, you can go straight to a hospital or to one of our tertiary care centers. So it's a really interesting healthcare, and it's considered the largest free universal healthcare in the world. So there are some other countries that have it, but as far as I know, Brazil is the largest because we actually have a lot of people here. But not everything is perfect, of course. So this is kind of why we need global surgery and global health in general. So I wanted just to show another side of the story. This is a very, very old picture. I'm not sure exactly where. I think it was in the north of Brazil, but it's real. I mean, I've seen things like this in here, even in my city. Sometimes the hospital is overcrowded and there are people in the hallways and they put the beds there, and like sometimes this happens. And so there are still several problems. One of the ones that I said here is that there is limited access in remote areas. So for example, the primary care centers, there was a very, very big project in Brazil from 2002 on called More Doctors, that was meant to create more primary care centers in remote areas. So they created a lot of it. So this is less of a problem now. However, tertiary care centers and secondary care centers are still a problem. And sometimes people have to travel a lot of hours to get access to, I don't know, an ophthalmologist or to get surgery. So it's still a problem, especially in the north and northeast of Brazil. Also, the overcrowded hospitals and tertiary centers. I worked in a tertiary center here after I graduated. It's like an urgency center, but if we have something that is really big, we can, like some people that get there and they need very specialized care, we send them to a big hospital. But if it's like myocardial infarction, we can, for example, treat it there. So there were times during COVID that it was really difficult. So it was overcrowded. And one of the things that I like to say is that where I work, we only had 2 respirators. And there were times that we had 20 people in a created ICU, which was a field hospital. So it's like a military hospital that they put right next to the tertiary center. And there were 20 beds and only 2 respirators, and a lot of people needing a respirator, for example. And we had to choose who would get the respirator. So yes, sometimes it works very well, but there are times that, for example, when COVID hit, many people were really sick at the same time. And of course, this makes it more difficult. So, and also one of the big problems that I see is that sometimes we have a delay in diagnostic testing, imaging, and surgery. So I think it's a big pipeline that I see, especially if you go to those remote areas. So maybe sometimes you can have really easy access to primary care, but if you need to do some testing or imaging, a CT, an MRI, or even schedule an elective surgery like a hernia repair, it can take years. It happens in big centers. For example, in my city, it's a very big city, it has 2 million people. Sometimes it's only a couple of months. But then if you go to a rural area of Brazil, it can take years. So I was only speaking to one gardening worker here yesterday, and he said that his hernia repair took 12 years to be scheduled. So yes, we have a very beautiful, functioning, free healthcare system, but there are still problems. And this is why we need global health and global surgery. So moving on, I wanted to show you a little bit, especially for the students here, some of the projects that I have worked with in the past, just to show you that global surgery can mean a wide range of things, and you can work with a lot of specialties. It's not only social medicine, for example, which is a misassumption that a lot of people have. So I have worked with projects with gender equity in subspecialties. So for example, I was invited by some people from Scotland to do a neurosurgery work in gender equity. So it's going to be a global project. And I'm really excited to work on this. Just wanted to say that, for example, this is one of the options. The first project that I worked with, as I mentioned, was a pediatric trauma project. So we went to the hospital and we analyzed how the providers did the A, B, C, D, E for the kids that arrived there. And it was really interesting. So it was more trauma-based, and it was an amazing project to start with, but it's something that, for example, you can do. So it's not only gender equity and social subjects. You can actually study trauma itself. We also studied in PGSSE gender equity and research. So one of the projects we're working at is analyzing authorship in manuscripts in Brazil and other Latin American countries to see if there is a difference between men and women publishing, both in first author and the last author, which is usually the primary, the senior author. Okay. One other work that I'm working right now with Team India is about isolated TBI, which is brain trauma. So really very interesting. We're studying a little bit about the epidemiology of brain trauma in India. Really, really interesting project. Another one is about blood donation. Right now, I'm working with a team from Guatemala to analyze factors that make people from Guatemala not donating a lot of blood. Here in Brazil, people actually have a culture of just going to one of the centers and donating blood for no reason. In Guatemala, for example, this doesn't happen. And with COVID, they canceled elective surgeries. People didn't go to donate blood. And so we're trying to study this cultural aspect and why people are not donating blood there. We also studied a little bit in PGSSE last year about the number and location of surgical subspecialties in Brazil. So like I said, sometimes access to surgery in remote areas is difficult, and we actually saw this in our research. So it was really interesting to see that there are some subspecialties, like, for example, neurosurgery, there are practically non-existent in some of the states. So this is something that really has to be fixed, and because of course people need it there. And it was really, really interesting to learn more about this. Also, I'm working on a pre-hospital care simulator with a team with people from Chile, US, Guatemala, and it's a really, really interesting Tourniquet simulator. And it's also something that is really different, but wanted to just put it here so you can know that it can be something to be done. So we're working on an MIT challenge, and it's a Tourniquet Simulator. It's supposed to be low cost and to be really easy to use in low and middle income countries, for example. So it's something really interesting. I know that some people in PGSSE are also applying for other challenges for simulators. So I know that Dr. Fabio Botelho, which is one of my mentors, he also has a very big dream of making pediatric trauma access and care better in the world. So I know that he's applying for a simulator challenge as well. So just something that I wanted to say here, because I know that people in the audience have a lot of ideas, and I just wanted you to know that everything can be global surgery. And last but not least, we also did a very, very nice project. You might have seen in my social media if you follow me, about COVID surgical backlog. So we were trying to see how many procedures were delayed or canceled in Brazil during COVID. And we actually found out that more than 1 million surgeries were delayed or canceled in Brazil. So very interesting result that we had. And as next steps, since Rohini said hers, I'm going to say mine as well. I think it's really interesting for you guys to know that it doesn't end here. So I'm just starting as a vice chair and associate member in the Association of Academic Global Surgery. So I'm really excited to make some change there and be able to, get inspire more people and get more people from other countries to be involved with global surgery. I also want to keep involved with this kind of associations. So I think it's really, really good for us, and especially for advocacy, to speak out. So I think social media also plays a very big role in this. So you can tell people what global surgery is. I know that many of the people who follow me have learned about this field because I talked about this. So I think this is very interesting, and it's one of the ways that this field is actually growing. Something else is I really want to keep involved with research. So I want to do an MPH. I'm not sure still when I'm going to do this, but I want to do this master's in public health. I think it's going to be a very big next step for me. And ultimately, when I'm an academic surgeon, I really want to be studying about other countries and other health care systems. And I think this would be my next steps. So thanks everyone who listened to me.
Thank you so much, Isabella. Next up is Shreenik.
Can you guys hear me and see my screen?
Yeah. Perfect.
Okay, perfect. Wow, that's a lot of work between Rohini and Isabella. It'll be really hard to follow them, but I'll try my best. I have about 5 minutes to introduce myself, talk about my journey, and also I'll try to talk about one project that I did. So I started my journey in China, in Sichuan University, West China School of Medicine. As you can see, the first picture, it's with my friend in front of the campus. And I ended up doing a master's in global surgery at McGill University, Canada. And obviously right now I am working as a research fellow at PGSSC. When I started my master's in global surgery, the first thing we were taught is the definition of global surgery, which is aiming to provide equitable and improved surgical care across international health systems. And when I looked at the global surgery literature, it was mainly focused on metrics, data, and definitions. And I was fine with it, but then came time for me to work on my own thesis, and that's when I had to dive deep into what's global surgery for me. And that's when I realized that my experiences in China can make an impact on my understanding and the importance of global surgery. So here I am showing you the pictures of a devastating earthquake, magnitude 8 in Sichuan. And during that time, they had no protocols, very low preparedness in handling any kind of mass casualty incident. However, when I was there in 2013, the results were very different. They had another earthquake of similar magnitude, and it was very evident that they had done something to improve. And that's when my research question and my project started. And I wanted to know if if a low and middle income country like China and poor resource setting like Sichuan can actually do better. Can a high income country and like Canada and Quebec can also do the same? So I wanted to know what's the preparedness levels in both the countries and both the systems. So in the project, I took two systems as we talked. One is the McGill University Health Center, where I was doing my master's, and the other was the West China School of Medicine, where I practiced and did my internship. Just to give you a scale at what they work at, West China School of Medicine receives about 200,000 inpatient visits in 2018, and about 175,000 surgeries it found in 2018. And in a comparison study, they found between the two earthquakes of 2008 and 2013, the ratio of dead to injured dropped from 18.5% to 1.5%. And West China Hospital was a major contributor to this. So obviously they were doing something better. And I just wanted to know what that was and if they were willing to share it with the rest of the world. You can see this is the West China School of Medicine. It's huge. They have an expansive campus. For McGill University Health Center, it's again a very big university hospital with about 40,000 inpatients yearly and about 35,000 surgeries. And it's one of the top tertiary and paternity care providing hospitals in Canada, especially in trauma and emergency care. And you can see McGill University Health Center is no small. It's also very big. For the methods, we did a background literature study, and we did conduct a survey with all the doctors. And for the literature review, we looked at all the different the preparedness guidelines and trauma guidelines all around the world. And obviously, we focused on Sichuan's earthquakes and the Montreal shootings, and we wanted to know how they responded to these kind of events. And then we did a survey with 5 major aspects of triage, stratification of hospital, pre-hospital care, quality control, and training and teamwork. And in conclusion, the study focused on informing the hospitals about different mass casualty incident protocols and guidelines existing in different parts of the world, and to facilitate the formulation of studies. So we found that exposing hospital staff to different disaster principles and practices will motivate them to get involved in administrative and planning components. As a take-home message, what we found is frequent simulation training, which the West China Hospital is doing, can actually help prepare for any event, just like in a mass casualty incident, better. And in some cases, in this case, West China Hospital, which is a more experienced system, is superior to a more advanced system, which was in McGill University Health Center. Well, that's about it for me. And yeah, you can see that's a picture of me and China looking towards the Great Wall of China. And if you're wondering if I did make it to the top, I did. And yeah, that's it.
That's great, Shreenik. And last but not least, we have Joyce.
Thank you so much. Let me share my slides. Hello, everyone. Hello everyone, I'm Joyce, and let me start with my slides. My journey with global surgery is still young, but I will share my experience as a clinician. So I stay or live and work in Uganda, which is a small country in East Africa somewhere. According to our recent population census, we are over about 41 million people. About 51% of that population is under 18 years old. Only about 4% of us are covered by a private insurance healthcare policy. Ideally, we have a public healthcare system or some, but that's largely insufficient. And our maternal mortality is unfortunately still high, about 336 deaths per 100 live births. And one of the reasons for that maternal mortality is, of course, poor access to health, and in this part, surgery and emergency services. So Uganda is also a beautiful country. We have one of the largest and longest rivers in the world, which is River Nile. We have very good long distance runners, as you can see from all the gold we got in the recent Olympics. And we have the cheapest Rolex. In Uganda, you can get a Rolex below $1, which is right there. So I will start by talking about COVID in Uganda. When COVID came, I was still a student in anesthesia and critical care. And we saw the whole entire, thing unfold at first in Wuhan, China, and as it spread in Europe and North America. We detected our first case of COVID in the 1st of April, that was 2020. And as the cases rose, we locked down. We had a very fast, very restrictive lockdown. When the lockdown was eased, we saw the first wave of COVID-19. It peaked from around September to December. I was a student by then, and I volunteered in the COVID ICU. We went on to have a second wave, mainly predominated by Delta, and that spanned from around May to July 2020, and by that time I'd been hired as an anesthesiologist. We have a total recorded deaths estimated to be around 3,000. So my experience in the COVID ICU, is sort of a reflection of everyone else. We were mad with lots of patients. Unfortunately, we have a young population, so in the Delta wave, we were hit so badly by people in their 30s and early 20s dying. That was so unfortunate. We even got to a point of intubating some of our colleagues and classmates, which we thought would never happen. So of course, at the peak of the wave, there was a lot of inadequacy in terms of all sorts of resources, which included PPE, nurses, doctors, respirators. All utilities were basically inadequate. It also showed a lot of healthcare disparities because of a very low healthcare insurance coverage. When the public hospitals were filled to capacity, the patients, of course, spilled over to private hospitals, and most of the patients could not afford healthcare, and that was really sad. Evidently, it had a huge psychological and economic impact on all of us. So I did work in the COVID ICU for the first wave, and then I officially got hired to work in the COVID ICU during the second wave. And after that, of course, one of the populations that were badly hit in Uganda during the second COVID wave were pregnant women. There was an ICU that was starting up in Kawempe, which is a national referral hospital, and there was only one anesthesiologist at the time. So I was transferred to that public hospital. It's a public maternal and pediatric hospital, one of the busiest hospitals in the world, conducts almost 100 deliveries, 80 to 100 deliveries daily. that includes both C-sections and normal deliveries. So we were hired to man the Directorate of Anesthesia that spans from taking care of theater, ICU, of course, education that includes residents, undergrads, and research. So the hospital looks like that, and that's our humble ICU bed. Right, we started with it's about a 4-bed ICU capacity. It's supposed to be mixed. That's both maternal and pediatric. And we started with a transport respirator and monitors. So we hope to expand. Some of the goals that we have as a Directorate of Anesthesia is to reduce the maternal mortality and morbidity. And of course, that includes access to specialized anesthesia services, specialized critical care services, and emergency, because with obstetrics, you're always having an emergency. So we hope to provide timely access to emergency and critical care obstetric services. Some of the causes of mortality are preventable, for instance, hemorrhage. We also hope to advance the field of obstetric anesthesia and critical care through research and evidence-based practices. And we also hope to, improve access to labor analgesia, because currently less than 0.5% of the women admitted there to get labor analgesia. Some of the challenges that we have encountered as we've started the ICU have been resource inadequacy. It is a public hospital, so sometimes you don't have access to labs, sometimes you don't have access to investigatory capacity. You have to have a good clinical acumen to be able to work there, because you're the anesthesiologist, you're the nephrologist, sometimes you're the psychologist for the patient and the physiotherapist at the same time. Yeah, so we've had to develop that and agility, because, and this is where again global health comes in, because sometimes what you read in the textbook cannot be translated and practiced in your environment, and you have to be agile enough to understand how to be able to help a patient in that interim. The other thing is, of course, burnout. So thank you very much. That's it for me. This is a patient of ours that we worked on. She was 21 years old, and she stayed with us for about 21 days in the ICU with postpartum eclampsia and complications of health and acute kidney injury. She got that. Thank you so much.
Wow, thank you. Thank you all for sharing your journeys and passions with us. I think with the growing awareness that global health, global surgery, and global anesthesia have for too long been dominated by individuals from high-income countries, we're so excited to hear from all of you panelists who are from LMICs and are passionate about giving back to your communities through various avenues. And what's even more exciting is that all of our panelists are young leaders in global surgery and anesthesia, and you've all been leaders in your respective fields. Our hope is that today is one of the many events to come that really highlight the voices of emerging leaders from LMICs who will continue to push forward the field of global surgery and global anesthesia and revolutionize it. And with that, I'd like to move on to some questions to get us started. The first question, I'm going to first direct this to Rohini. A huge focus of today's Grand Rounds event is hearing from those who are from LMICs who are doing work in LMICs. How can we lift up the voices of grassroots and the folks who are doing the work on the ground in the field?
Thanks for this question. I think it's really important and relevant to today's discussion. I think we can't really uplift voices from the grassroots until those voices recognize and relate to what the concept of global surgery is. A lot of rural surgeons find that what they're doing may not be relevant at a global platform, which is kind of the first thing that I saw when I read the term global surgery. I could not see what we are doing in a very small hospital, and how could the knowledge that we are learning here be shared with other people be relevant, just because of the fact that most of the academic space initially has been taken up by high-income country technologies, and we feel that what we're doing is nothing revolutionary as such. So I think the first step is to kind of understand what people think when they think of global surgery and to change that mindset. And then once we've done that, to amplify those voices which are truly relevant in today's world. I think the first step should be something like this, inviting people to be on panels and making sure that panels are equitable, to have an equal representation of LMIC people and HIC people, inviting them to be keynote speakers, and also asking them to publish in journals and making publications perhaps free or low cost, because I don't think a rural surgeon who has a lot to tell through a publication would be able to pay for that publication per se.
Totally agree, Rohini. Shreenik, do you have any thoughts?
Yeah, sure. Yeah, I absolutely agree with Rohini. That's correct. Awareness is the key. And I have an idea about like to help grow global surgery in LMICs. Global surgery as a term right now is mostly the like transferring knowledge from HIC to LMIC. But that's not the case. We have to explain that to the different leaders in the field, that we can even learn from the LMICs. They're doing a lot. They're doing a great job. They're doing a great job in poor, low resource settings, and a lot can be done. And encouraging them to show their ways to us in the HICs can actually help uplift their voices, and obviously do more work with them, and learning from them can actually help. Actually, in the case that I showed in the project that we did, that's exactly what I was focusing on, is that explaining that a more experienced country with mass casualty incidents can provide a lot of learnings to an HIC where rarely any such events happen. So yeah, that's my thought.
Thank you, Srina. I'm hearing from both of you that there's this usually inequitable relationship between HIC and LMICs in the field of global surgery, but there's so much to be learned and gathered from our colleagues and LMICs who are doing really fantastic work, but sometimes, as Rohini has hinted, they don't feel like the term global surgery, global anesthesia really apply to them, because all they see in the literature is really folks from high-income countries. And I'd like to delve a little more into the relationship of HICs and LMICs in global surgery efforts. My question is, what are some examples of successful HIC and LMIC partnerships that you've seen? And I'd like to direct this question to Isabella.
I think a great example of this would be PGSSC, for example. So I've been working with PGSSC, as I said, since 2019. So I had the experience to work with multiple people and with many countries. And I think one of the successful things that they do is that they really work with studying the decolonization of global health, and we do anti-racism lectures. And I feel that when we are collaborating with the countries, and for example, me coming from a LMIC and as a medical student in the beginning, I never felt like our work was undermined, and I always felt that every single idea that we gave, every opinion that we had was listened by everyone, was taken into account, in that I never ever had the feeling that, for example, the Harvard folks were trying to do everything their way or imposing anything to us. They would also value our opinions, and we felt like I always said, and it's not only me, but in the Brazilian team, we always say that it's like a family, because we're really friendly. We acknowledge everyone. We always want to work together in the best way. So I think this is very, very important. So to be able to have this kind of partnerships where everyone works together and everyone is valued, and you don't have problems with, for example, authorship. So authorship doesn't go to only to HIC people, it also goes to LMIC people, and there are efforts to the decolonization of global health. So you can see that people are trained for it, for example, which is something that I think it's really important. And I would say that this is a very good example of a successful partnership. I think that the other panelists might have other ideas. Maybe Joyce has something to say, I'm sure.
No, Isabella, I don't have anything to add. Thank you.
Thank you. Thank you, Isabella, for highlighting that successful partnership that you've been a part of. But it's, I'm sure with the good, there's also the bad. And I wonder how you panelists have resolved some tricky conflicts that have occurred in HIC and LMIC partnerships. And first, I'd like to direct this question to Rohini.
So I think from the year and a half that I've been involved in global surgery work, particularly in research, conflicts are bound to arise. And the number one thing to prevent conflicts entirely is to work with a group of mentors and colleagues that you trust, and that have like a history of being very equitable in their approach when it comes to authorship and laying down responsibilities. I think for someone in India, what happens in India is that a lot of students want to engage in research, but the opportunities to engage in research are low. And this is in contrast, I think, to the United States, where the professors have a lot of research ideas and not all students have time to engage in research. So there's that imbalance. So in India, we just tend to go for any opportunity we can find, and we don't have the luxury to pick and choose. But I think the more and more I got involved, I realized the importance of associating yourself with the right people and the most equitable groups in global surgery. And I've been very lucky with that. But if you are in a conflict, I think if you are in a well-trusted group, you should definitely approach your mentors. They will smooth the process for you entirely. In my experience, it's been very, very helpful. And at the same time, what it taught me was that to lay down expectations in the beginning of the project, to talk about the same expectations during the project and at the time of publication, which is very, very important. And if you still don't have trust in the beginning, it's always good to have like a written email being sent, so you have proof that this is the authorship sequence that was decided, or these were the rules and responsibilities that we talked about, to reference back to.
Thanks, Rohini, for that. Shreenik, please share your insights.
Yeah, so one of the most tricky situations in global surgery is a global pandemic, which is COVID-19, which is going on right now, I believe. Because when I'm trying to do like any global collaborative work and data collection, it's so hard to get to regions and areas where right now, it would have been easier 2 years ago, but right now it's just not possible. And other tricky situations that I have faced personally, I wouldn't say that I have solved it. So I'm not trying to teach somebody anything, but some things like, obviously there are political situations coming in between, especially working with sensitive areas like China. Not everybody is very helpful and very open with that data. Data collection it's somewhat secretive sometimes, and sometimes you have to follow the ethics, and which you have to ensure the ethics are being followed, but you don't know because you're not there personally. And some other examples are like, again, sometimes, again, working in China, I understood that they have restrictions with websites and softwares that they don't use. Like for 6 years, we never used YouTube, Google, Facebook. And when we were going to start data collection from Canada, we wanted to use certain certain websites that we use for surveys, and they were just not responsive to those applications or softwares. They had to use Excel, which obviously increased the workload. But yeah, those are a few examples that I can share. I'm not saying that I solved them, but I did face them.
Thank you. Those are all incredibly tricky situations and challenging situations. And it seems like both of you have figured out some ways to think about it and also brainstormed ways to overcome it. But it seems like it's undeniably a burden and the challenge that folks face in these HIC and LMIC partnerships. I'd like to shift gears a little bit and talk about some LMIC and LMIC partnerships, which we have also seen as emerging in the field. What are some examples of successful LMIC to LMIC partnerships that you've seen? And we'll have Rohini start us off.
So I think two of my lived experiences with LMIC partnerships. One was I've seen Dr. Roy working with a group of multifaceted researchers in the global south. And the second is definitely something that started as a north to south partnership, which is the NIHR with its hubs in global surgeries across countries like India, Pakistan, Mexico, Rwanda, Nigeria. And those I've now seen that, so now the India hub is leading a project called the Giraffe RCT, and they are going to spread that across the other hubs. So instead of UK kind of deciding what study we're going to do, it's more about each hub that they can decide the studies that they want to start up, and they can collaborate with other countries as well. So I really liked that transition of seeing the capacity building throughout the years from the north to south, and then the south-south partnerships happening. I think the biggest south partnership that has, and I think Joyce can shed light more on that, is COSECA. I don't have a lot of knowledge on that, except I think that approximately 14 countries came together to make that college. And I think that LMIC partnerships are truly the best way to impart knowledge to each other, because these are countries which face similar issues, and they can find similar solutions as well if they come together.
Thank you, Rohini. Joyce, would you like to share your thoughts and experiences with LMIC to LMIC partnerships?
Thank you, Eric. So I can talk about CHESA, which is an association of Central, Eastern, and Southern surgeons. They basically wanted to build capacity in Africa, so they have gone on to train and to sort of formalize surgical training and to develop subspecialties like pediatric anesthesia, neuroanesthesia. So they're enrolling and training fellows in those various disciplines. Yeah, and yes, and I think that has been able to build capacity. Sorry.
Thank you, Rohini and Joyce both. I think talking about LMIC and LMIC partnerships is related to really claiming the space for LMIC individuals to have a voice in the field. And I think that coincides with this growing movement to decolonize global health and decolonize global surgery. As young leaders of the field, what do you consider your role to be in the movement to decolonize global surgery, health, and anesthesia? Shreenik, could I have you please start?
Yeah, sure. So the question that you just asked, actually, I did propose this question to my supervisor when I was doing my master's in global surgery, and I was asking, what exactly can I do? And how can we improve the status of surgery, situation of surgery all around the world? And that's when he answered like, okay, so the first step is to increase the number of surgeons and train more surgeons. And well, my answer was, obviously, I'm not qualified enough to train more surgeons. So how can I help here? Like, what is my role here? And that's when we came to a discussion, and we discussed, and we're like, okay, so my role is to do research, to create awareness, to bring more people in, and to let everybody know what's going on. And that's only by more research and more work in LMICs. And I believe that's global surgery to me, more academic work to explain others that we have a shortage, we need more people, and we need more people to be involved.
Thanks, Shreenik. Joyce, would you like to go next in talking about decolonizing global health and global surgery?
Yes, I would just like to add and say, of course, on platforms like this, when we're able to share our perspectives from low and middle income countries, I think that can help inform some of the activities that we can implement together and sort of make a change. And again, from my perspective, what I would like to do is, as I become a mentor and grow, I would like to help the students to be able to understand evidence-based practices, but to be able to be agile enough to tailor them to our settings. Because there's some things you cannot just directly translate from a research article to a clinical setting. So as the disparities or equality in research opens up, we'll hopefully be able to share our perspectives on ground. But for now, I would like to tailor the evidence-based practices that we see in other settings, and then to be able to look at our clinical settings and apply them in our social and cultural context.
Absolutely. Joyce, you've mentioned mentorship, which I think has been key to all of our career development, but especially perhaps more important in global surgery. And Rohini, I'm going to direct this question to you. How can the institutions and faculty specifically from high-income countries support global surgery and global anesthesia trainees who are from low and middle-income countries?
I think the first step would just be to listen to us and kind of figure out what our expectations are, and to lay down your expectations to us regarding projects. Research is not really a part of our curriculum here, at least at the undergraduate medical school level. So a lot of us have kind of gone out of our way to take up courses online, talk to mentors that take out the time to talk to us and guide us on certain things. So if you expect us to do some logistical regression, we can't do that. But if you want us to do a literature review, read papers, write something, get back to you, we can do that as like a baseline. And then of course, people do start learning statistics as they go on, and they can fulfill those expectations as well. At the same time, I know a lot of people are trying to train outside of India. So if you can support us in that through a letter of recommendations and putting in a good word for us, if purely merit-based, of course, then that's also a silver lining.
It sounds like there are some concrete things that HIC folks can do to support our colleagues and counterparts in the LMICs, especially trainees. Isabella, do you have any thoughts on this question?
Well, I would say that mentorship is key for sure. So when you have a strong mentor that can help you guide you through this pathway, this really helps a lot. So I think it's very good to have someone that is more involved with the field and knows more and can help you get more knowledge and even improve your skills. I think this helps a lot if you have someone that can help that. And I would say that something that I feel sometimes is that there is sometimes, coming from an LMIC, we don't hear a lot about opportunities or even about global surgery and other new fields that comes. And most of the times what I notice is that it first starts in HICs. So I think it's part of the role of people from HIC is to use this privilege to actually inspire us and to let us know about these opportunities and to help us get to know more about these fields and to get involved with this. So I think mentorship, but not only mentorship, even, having a colleague that is from an LMIC, don't have to be their mentor, but as a friend, as a colleague, I think these are ways that can really empower people from LMIC and actually help a lot in these partnerships.
Absolutely. Oops, muted myself. I think this gets us to the question about how we see our careers expanding and advancing in global surgery and anesthesia, and what advice you have for folks with similar goals. So I'll just start off with Shreenik.
Sorry, could you repeat the question? Sorry, I did not get that.
Absolutely. What do you want your future in global surgery to look like? And what advice do you have for folks who are in our shoes?
Okay, that's tricky. My future in global surgery, obviously, to like, when I first got into global surgery, I didn't see too much of information on how to get in there. So my goal is to create awareness and to let others know that this is not something which is an anonymous group. It's open to all, and everybody should be given equal opportunities to join. And yeah, that's about it. Yeah.
Great. Rohini, do you have any thoughts?
Yeah, I resonate with Shreenik. When I kind of started dwelling into #global surgery on Twitter, I found the space extremely welcoming, primarily because I saw a lot of women of color from different ethnicities and backgrounds who looked like me. And they were being respected for everything that they were saying at a global platform, which made me want to advance in this field because I finally could see someone who looks like me in healthcare at a global platform. So I hope that I could be that person for someone in the future. And I have gained everything that I've gained is definitely, like I said in my introduction as well, because of my mentors. And I do take out the time now to mentor people who want to get into global surgery. And I hope I can continue doing that as well. The only advice I have is to read, to listen, to be active on Twitter. I think Twitter is a great space to start listening and talking about global surgery and to build a core network of mentors, mentees, and peers and colleagues, because they're the ones who actually kind of help you navigate situations, good ones and the bad ones as well.
Thanks, Rohini. And Joyce, earlier you talked about what you wanted to accomplish as a mentor. So if you could also speak on this question about how you see your future in global anesthesia and what advice you have for trainees in your shoes, that would be great.
Thank you, Eric. So I would like, coming from a place where there's lots of health inequalities, I would like to, aside from the curriculum that we learn, which is the medical curriculum, I would like to be able to mentor people to be leaders in the place of in the place of health, because in where, for instance, we work, you have to sort of grow up so fast, past medical school or past living postgraduate, and there are certain things that you're not going to be taught in class, but you sort of have to learn. So I would like to become a better leader, become a better advocate for my patients, and I think that's something I can learn from all of you. Yeah, and also from sort of a business perspective, entrepreneurship in health to bring about social equity, so that we can be able to solve some of our problems and not always rely on that sustainable solutions. Yes. Thank you.
Thank you, Joyce. Really interesting what you said about the business model and the business side of healthcare and medicine. And I know that some of you can get training through in that field through a lot of avenues. Isabella, I think you had mentioned MPH, for example, which kind of touches on that. So if you could maybe speak on your aspirations for your career, that would be great.
Okay, sure. First, I just wanted to say something about the future of global surgery. I believe that social media plays a very big role on that. I think that social media use for education was really catalyzed by COVID-19 and the pandemic. And there were a lot of webinars, and everyone started to, in medical schools, for example, to learn using Zoom and lectures anyway. So I think that now more than ever, this is a very unique way to help spread the word and make people aware of global surgery and global health in general. And I think social media plays a really, really big role on that. And I remembered that in Team Brazil, one of the senior faculty members was speaking to one of the students, and he is one of these people that don't have social media, don't use any kind of internet related. They just have like a phone and, you know, take calls and sometimes use Zoom, but not usually. And those people, they usually don't see the value of social media, at least in my experience. But it was amazing to hear from him that he thought that global surgery was emerging in Brazil because of the students, and they work in social media and Twitter and even Instagram, which is really big here in Brazil. So he said that he acknowledged that most of the work that was being done this past couple of years were from those students that were speaking to other students and making people know what it meant and know about the research projects. And this actually, he mentioned that he saw a very increase in the interest of other people, and probably they didn't have interest before because they didn't even know this was an option. So it was really great to hear that from someone who doesn't usually use social media, because I think it's true. And it for the future of global surgery and, you know, policy making, this is going to play a very big role. And about my pathway specifically, I really want to do an MPH. I think Shreenik would be perfect to speak about this. But it's a master's degree in public health, so it's more, you have a lot of pathways that you can choose, but all of them are related to public health. And I think this is very good to get to know more about other health systems and to study your own health system as well, and to get involved with people that want to go through the same career path. So I think that for surgery, this is really interesting because at least in LMICs, I'm not sure how it is in HICs, but when I was a student, I heard from a lot of professors that public health and surgery were two completely separate things, and they could never, you know, be the same thing. So you could either work with public health or be a surgeon. So when I saw that this was an option, I think this is why I really wanted to start working with global surgery, because these are two things that at first I thought were impossible to be both, but I learned that it is possible. So I've noticed that a lot of surgeons in the US, for example, they do MPH, and they use this knowledge acquired in the MPH to do research and be an academic surgeon and work with other countries and do partnerships. So this is something that I aspire to do, and it's something that I never knew was possible coming from an LMIC. So I think that's it.
Thanks, Isabella. I think the underlying sub-theme of our discussion, which I feel like has been for all discussions, has been COVID-19, how it has impacted our work as well as the field of global surgery. I'd like to direct our final question of the roundtable discussion to Joyce, who has worked so closely with patients with COVID and in the ICU. The question is, How do you see surgical systems improve in the face of COVID, and how the pandemic has enabled global surgery partnerships to grow?
Thank you, Eric. So, of course, with the disaster of COVID-19, healthcare systems came to a halt, especially the performance of not only elective surgeries, but also emergency surgeries at some point were affected because there was a constraint on all forms of resources, human and otherwise. In my country, what I feel like has grown is there's been some political will, and also from lots of our funders and collaborators from HICs, that we've been able to develop the critical care system and the anesthesia system as well. And the government is now more interested in training more anesthesia providers and placing them, sort of decentralizing the healthcare system, because most of the critical care services were found in the capital city before. So I feel like that's a plus. And I think if we capitalize on that, the healthcare system will be able to grow. Two, I feel like telehealth has also grown with social media and platforms like Zoom. We are able to sort of do, for instance, pre-hospital visits, both before surgery and even post-surgery. And so those are like teleconsultations, but also within us, for instance, as the Association of Anesthesiologists and Intensivists in Uganda, we were able to build a platform that can be used for teleconsultations. For instance, we'd go to ICUs that are outside the capital city and would provide some mentorship for a number of weeks, and then let them run the ICU. They sort of learn from us. So I feel like the collaborations both within the country can be strengthened through telemedicine or through social media platforms. I feel like that can grow. Thank you.
Thank you so much, Joyce. That was fantastic answer. All of everyone's presentations, life stories, pearls, were all extremely inspiring to me. Just a couple overarching themes that I noted, that all, that number one, the power of social media in not only communicating with people, but also establishing careers, making first steps in global surgery for those students looking to get more involved. I think an acknowledgement that the work done in low and middle income countries is not just something of potential, but is already quite accomplished. And there is a lot, I think, that high income countries have to learn from the example that many low and middle income countries set in the field of global health, in health equity, and in global surgery. I think you are all quite living proof of all of that. And I'm very inspired by all of your stories and presentations and your work. And then finally, how COVID sort of highlighted all of these things. So thanks again for all of our panelists for your wonderful presentations and for this lovely discussion that we've had. I do want to get to our audience questions before we leave for the day. So the first question from our audience is directed to all panelists. Do you view global surgery as a multidisciplinary discipline outside of medicine and surgery? What are ways we can involve physician assistants, nurses, technicians, and other public health professionals? Why don't we start with Rohini? If you wouldn't mind giving that a crack at that answer, and we'll go from there.
Absolutely think that it's definitely a multidisciplinary field. I don't think that a surgeon can perform surgery alone. They need the scrub nurse. They need a radiologist to make a preliminary diagnosis. If there's a fracture site, you can't start without getting an X-ray, and you need a C-arm in the OT, so you'll need a technician for that. So I absolutely believe it is. And I also think that after the launch of Lancet Commission on Global Surgery, there's been a recent launch of the Lancet Commission on Diagnostics to recognize the work of pathologists and radiologists. And I think that can definitely be weaved into the work we do in global surgery as well. And apart from the nurses and the public health professionals, I think the role of diagnosticians needs to be more emerging in the field.
Thank you. The second audience question, I think, is related. This question is, could you please discuss the importance of participation from other specialties to reach the diagnosis before reaching the surgical intervention? I think to tail off on that, I'm hoping that, Joyce, would you like to answer that question?
Yes, I will definitely try. So I think like in low and middle income countries, due to this, the scarcity of healthcare resources, we would definitely benefit from what I'll start as a stage one, like a community healthcare worker. And this community healthcare worker can serve as an intermediate between the healthcare system and the patient at home. In my country, we call them, for instance, VHTs, and they help to bridge that gap for mothers to sort of check on them and do antenatal visits at home. So I think there's a big role that specialists outside the hospital can play to be able to bridge that gap, especially in areas that are hard to reach, or even in areas that are hard to reach, or in facilities that may be constrained one way or another.
All right. Well, that is all the time we have, unfortunately. I'd like to thank all of our 4 panelists for sharing their insights today. It was incredible to hear about all of your experiences, life stories. And as I'm growing in my own career in global surgery, I'm excited to work with and learn from all of you. And we'd also like to extend a thank you to all of our global audience that joined us for the grand rounds today. I encourage you to keep the conversation going on Twitter, mentioning CHESA, GSSA, and hashtag CHESA Grand Rounds. We'll post the recordings of this grand rounds on YouTube and share it through our Twitter. Our next grand rounds, titled Local, Regional, and Global Approaches for Anesthesia Capacity Strengthening, which will be co-presented with the World Federation of Societies of Anesthesiologists on October 14th to commemorate World Anesthesia Day. So please be on the lookout for that.
Thank you, Eric. And thank you again to all of our panelists, Isabella, Joyce, Rohini, Shreenik. Thank you to Eric for moderating, and for UCSF and the Center for Health Equity and Surgery and Anesthesia for creating and making this event possible. I just want to thank again all of you for joining us in the audience. It's morning here in San Francisco and our day is just beginning, but I know for many of you it's nighttime and your day is ending. I wish all of you a pleasant rest of the week, and stay safe. Hope to see you again soon. Bye-bye.